This is my history and physical on my second patient for adult gerontological acute care nurse practitioner program with UTEP. I have a 38-year-old Caucasian male, Mr. NH, with no past medical or surgical history that arrived in the ER today with complaints of diplopia, ptosis, and headache. Admission diagnosis is paralytic strabismus associated with right parietal oculomotor nerve palsy with diplopia and ptosis. He arrived stating that a few days ago he started having pressure in his sinuses and forehead that was radiating to both temples. Today he started to complain about double vision and left eye drooping. He denies any headache, head trauma, dizziness, lightheadedness, numbness, or tingling in any of his extremities. Denies nausea, vomiting, diarrhea. Denies chest pain, shortness of breath. Endorses a viral illness a few weeks ago that affected his upper respiratory tract, but he has since completed antibiotics that were given to him. He is otherwise healthy and works as an electrician. While in the ER, we did a CT of his head and got some, just a few labs, CBC, CMP, PTI-NR. We reviewed his past medical history, which was none. We did have him endorse some smokeless tobacco use, but not, he has never smoked tobacco. He also denies any illegal drugs or alcohol use. Family history: his mother had diabetes, his father had heart disease, his paternal uncle has heart disease, and another paternal uncle has died from an aneurysm. He has no known allergies and takes no medications. Review of systems all came back within normal limits except for the double vision, diplopia, ptosis, headache. He denied any weakness to either side of his extremities, left or right. He denied hitting his head. He denied having an extreme headache. It was just like a mild headache that has happened before. Vital signs were within normal limits. Temperature was 98.6, pulse was 54, respirators were 15, last blood pressure was 136/94, and his O2 was 97% on room air. He does have a BMI of 43.64, which puts him into obesity. His mental status for a 38-year-old was alert and oriented ×4. He was pleasant, cooperative, and speech was clear. There was no slurred speech. His integumentary was clear and pink. Skin was warm and moist. No evidence of any skin integrity impairment. HE and T, head is normocephalic, atraumatic, sclera, and anecentric. Conjunctiva was pink. Pupils were 3 millimeters, equal, round, and reactive to light. Neck was midline, supple, with no JVD. He had grossly no neurological deficits. He is binocular, diplopia, ptosis, right ear numbness, and generalized drooping to his face. Cardiac, there was no murmur to be heard. S1, S2 was present. His rate and rhythm were all within normal limits. Pulmonary chest rise was symmetrical on inspiration. Lungs were clear to auscultation bilaterally to anterior and posterior lung fills. No rales, wheezes, or bronchi. Abdomen was round with active bowel sounds, non-tender and soft, with no guarding or rebound tenderness. All extremities were warm and without edema. Pulses were 2+ and symmetrical bilaterally. Labs came back within normal limits. WBCs were 10.6, RBCs were 5.71, hematocrit was 48.7, platelets was 277,000, glucose was 98, bun was 12, creatinine was 0.85, potassium was 4.2. We did do a CT, and the final impression was no deficits or no definite acute abnormality of the brain identified. There was equivocal white matter low attenuations. Because the CT did not show anything, we did want to order an MRI, which happened actually the next day when I was not taking care of him. At this point in time, we were starting to think about stroke, but we ruled that out with the CT. We were thinking myasthenia gravis or other neurological issues like that. We were also thinking MS, which is what the patient was actually diagnosed with the next day once they did get the MRI. When admitting him and doing his admission orders, we did want to make sure that neurochecks happened every 4 hours. The MRI was done in the AM. Neuro was consulted to talk to the patient about the findings. We are also thinking nerve palsy with the diagnosis also. We also put in to monitor his diet and have a dietary consult because of his obesity. He was a full code patient, and we wanted to admit just to the observation since we had no definitive diagnosis, and kind of just wanted to monitor his symptoms. And that is patient number 2 for my history and physical.